Okay, good morning, good afternoon, good evening, wherever you are. Thank you for having me. And I'd like to thank all the participants for participating this event in the weekend, and our very distinguished speakers before me and after me. And of course, special thanks goes to Professor Mehmet Zileli for his continuous efforts to improve the worldwide education in neurosurgery. And I haven't seen the World Federation Education Committee this much active until Professor Zileli start chairing this committee. Um, and very sad, we learned Professor Vinko Dolenc passed, the master neurosurgeon, excellent friend, and the pioneer in skull-based surgery, in particular cavernous sinus surgery. He'll be remembered all the time, and he'll be with us. Professor Zileli asked me to talk about the surgery and functional preservation in vestibular Schwannoma surgery. So, like previous speakers pointed out, the goal is the gross total resection, or at least near total resection, if you are performing surgery. And you have to preserve neurological function and cranial nerve functions. And this should come with the minimal postoperative morbidity and no mortality at all. We made extensive, very significant advances in vestibular Schwannoma surgery since like early years. This is how people removed the vestibular Schwannomas in early 20th century. So how are we going to do it? I'll divide my talk in the cranial nerve functions, because neurological functions we almost always preserve, and I don't remember any case because significant neurological morbidity in vestibular Schwannoma surgery. Hearing function is important to know which approach you should choose to preserve the hearing if serviceable hearing presents. Middle fossa approach, if the vestibular Schwannoma is located very lateral in the internal acoustic canal, that gives you direct access to the intracanalicular portion, and very lateral. And retrosigmoid approach, you have to drill a lot, and then by just drilling, forget the drilling, sometimes even the sound of the drill can cause cochlear damage or hearing damage. So in those cases, I think if you want to perform the retrosigmoid approach, you have to have some fundal cap, some CSF signal in the lateral IAC. These are the two examples to show you the contrast between and my selection bias. So this is the case. We prefer retrosigmoid approach because there was this fundal cap here. So while coming that, we didn't need to drill the canal too much, cause the damage to the hearing. And in this case, there's more cisternal portion. You can argue against the middle fossa approach, but there's tumor very laterally. In this case, we perform the middle fossa approach and achieve excellent results in both cases, gross total resection with the hearing preservation. And these size tumors, we shouldn't be talking about facial nerve preservation. This size tumor facial nerve preservation should be 100%. So preservation of hearing in the middle fossa approach, I'll show you another case example. This is just short video. I'm going to skip some parts of the video. Linear incision or slight curvilinear incision. Middle fossa approach is an epidural approach. You don't see brain. You retract the dura of the temporal lobe. You identify your anatomy, bone anatomy, identify the GSPN, identify the geniculate ganglion. And geniculate ganglion can be identified with the high stimulation if you having a hard time with the identification of the GSPN. Then you drill the canal, you expose little bit posterior fossa dura, that's all. And you open the dura, release the CSF, putting the lumbar drain, not putting the lumbar drain, depends on the patient's age and the fullness of the brain. You can put it, I'm not against it, but in some patients you don't have to. That's your decision. And then finding the tumor, you see this is the posterior fossa CP angle. And then once you find, just gentle debulking here in this location, this size tumor, ultrasonic aspirators won't work. You have to debulk with the micro scissors. And then once you get there, the removing is becomes an unblock. You divide the superior, this is a superior vestibular schwannoma. You divide the superior vestibular nerve and remove the rest of the tumor unblock. And the hearing preservation should be at least 50% in these size tumors. And in this case, we were able to preserve the hearing, and she's been like tumor-free with the good hearing almost 15 years now. And what about retrosigmoid approach? In retrosigmoid approach, again, this is the case. There's a fundal cap here. So this is a good case for the retrosigmoid approach because we don't have to do the IAC. And another variation here, you need to be careful. A loop of the ICA can be very stuck to the IAC dura, and no retractors in the retrosigmoid approach. Don't try to be minimalistic, be maximally safe, and wide arachnoid dissection. Don't be afraid of doing the arachnoid dissection, please. You are doing glioma or you are doing acoustic neuroma or aneurysm. When you avoid dissection, you'll have the problems. Dissection, arachnoid dissection makes the surgery safer, not more harmful. So that ICA loop is attached to the dura of the internal acoustic canal. We're going to separate that using the sharp and blunt techniques. Otherwise, you won't be able to drill the IAC. And separating that, and then carrying the more dissection after that, in and out, and moving that ICA loop away from you, that brings the part of the tumor hidden under the nerves. And then identifying the normal anatomy, then the pathological anatomy, like we always do in neurosurgery, and drilling the canal with the ultrasonic aspirator or diamond drill or whatever you use. Recently, I started doing this with the more ultrasonic aspirators because we don't worry about catching it, and dissecting the intracanalicular tumor, separating, taking some fibers of the superior vestibular nerve, leaving some fibers on the facial nerve. So that gives you a manipulation opportunity. And then you see the cochlear nerve at the bottom, and sharp dissection techniques. And these are very sharp dissectors, thanks to Professor Kamiyama, and removing the rest unblock. Confirming that facial nerve is present. Again, good results. You can watch the entire video in the journal. What about facial function? And we always, neurosurgeons, we grow up with the retrosigmoid approach, right? So we love retrosigmoid approach. Retrosigmoid approach is the workhorse of the skull base or neurosurgery, and it's in our daily armamentarium. But I learned translab, and I learned how to use the translab and how to choose between. So when you're doing the facial nerve preservation surgery in large tumors, CUS 3 or 4 or whatever classification you use, level of hearing is important, right? If the level of hearing is very good and you think you can save the hearing, then you should do the retrosigmoid approach, because we know that translab will sacrifice hearing if you have a good hearing. And the depth of the tumor extension into internal acoustic canal, like choosing the retrosigmoid versus middle fossa, is also important. Choosing between translab and the retrosigmoid. Position of the sigmoid sinus, way anterior, way posterior, jugular bulb, contracted mastoid, small mastoid, or absent of the flow for some reason, congenitally or acquired. Thrombosis of the sinus is also important. You don't want to choose those surgeries in the part you are depending only one sinus. And of course, your experience is very important, but usually, most of the time, size is not important choosing between retrosigmoid and translap. Two cases I'm going to show you later. So this is the case, similar ages, similar symptoms, and no hearing. So if there's no hearing, but there's no canal involvement here. So I don't want to spend a lot of time drilling the translap here. I just can come and remove the tumor with minimal drilling or no drilling of the internal acoustic canal. Here, on the contrary, tumor is extension into the canal, no hearing. This is a perfect case for translap. So translap advantages. What is the advantage? You identify facial nerve right away. You don't worry about where the facial nerve is. You don't need to map. And so you have facial nerve in the canal. You can predict its course easily. And you can mobilize the facial nerve, but you have to drill the internal acoustic canal almost 270 degrees. If you do less than that, it's not big difference between retrosigmoid and translap. And it's direct route and almost purely epidural approach. You don't retract the cerebellum. You just open little bit presigmoid dura. That's all. Cerebellum is protected by the dura. And this is questionable. People found some less CSF leak and much wider anterior and superior exposure. And this is the very important thing. In retrosigmoid, doesn't matter how you do, you will have one or two patients out of 50, 100 with the intractable post-craniotomy headaches. That doesn't happen in the translap. Disadvantages is small unfamiliarity for the neurosurgeons. And if you have a wide inferior brainstem attachment and high jugular bulb, this can be very limited. And of course, main contraindication is the mastoiditis or chronic ear infection or mastoiditis. You cannot perform this approach. This is a above 3 centimeter tumor, no serviceable hearing, is perfect case. And you need to go to the lab to learn this technique, identify mastoid, do the mastoidectomy, do the middle fossa unlocking. Cochlear aqueduct is good exposure for CSF. You get the CSF, you relax, and you go intradural now. So all dura is here. Dura, I don't see even brain. I don't see cerebellum. Then techniques are same. Intradural techniques as the techniques we learn from Professor Yaşargil, right? Arachnoid dissection first, identify the normal, then identify the pathology. And as much as you can do sharp dissection, if you are doing blunt dissection, use the sharp instruments, not the blunt instruments, and no avulsion, no pulling, retraction, contra retraction. I'm retracting with my suction, and I am contra retracting with the other instruments away from the normal. And debulking. Keep exchanging these moves. Debulk, dissect, debulk, dissect. Don't be very ambitious, even in the small tumors. Hey, I can remove this. And your suction hand is the most important hand. You have to adjust your suction yourself, not your nurse, not your resident, not your assistant. And then you can achieve the gross total resection easily. And feeders, you see the feeders, there will be intradural feeders from AICA branches and extradural feeders coming from the internal acoustic dura. So once you get those, the surgery becomes less bloody. And here, when you come to the canal, don't use coagulation, please. You can burn the nerves easily. And decompressing and getting the tumor out. Okay, the rest comes. So you have the acoustic canal, you have the brainstem, and you meet to two planes. And when you meet the two planes, tumor is out. So gross total resection, abdominal fat graft. We were not putting lumbar drain after this, during these surgeries. The last few years, we start putting it. Almost zero CSF leak in translap, less than 2% in retrosigmoid. And another case, you can argue doing the hybrid surgery, like debulking and the radiation. But you don't go there with the aim, I'm going to remove subtotal, then I'm going to radiate. I'm against that philosophy. You go there, do your best to get the gross total or near total resection for any unforeseen reasons. You cannot do it. Of course, patient's function is very important. Stop, then you can do radiosurgery or you can observe. You don't have to do radiosurgery in every case if you perform subtotal, but you go there with the minimum near total, but the main goal should be gross total resection. Again, translab, beautiful dissection by our ENT colleague, but don't rely on the ENT. As a neurosurgeon, you should be able to perform translab approach, all these kind of approaches through the mastoid like yourself, and same with the endoscopic approach. You do your own transnasal endoscopics. Okay, and the fat graft retraction, very good outcome, facial nerve grade 2 early and grade 1. She finished the nursing school. And what about these large, long tumors with the cystic, like almost 5-6 centimeter tumors with the hydrocephaly? Again, same principle. Gross total resection, fat graft, and perfect outcome. Cystic tumor, same thing. Translap, size doesn't matter. Gross total, and you save the facial nerve. And sometimes you get these tumors. People perform retrosigmoid subtotal resection, tumor grows, and patient doesn't want to have a radiation. And this is a perfect case because it's a virgin approach. You don't go through the retrosigmoid, it's scar tissue. You go do the translap, remove the tumor, you can watch the surgery. Another case, this tumor was very large. They operated in Spain. They left this tumor and radiosurgery after it, and patient moved to United States, and now there's a large tumor, grade 3, grade 1, gross total resection. And post gamma knife recurrent tumors, patient has a good hearing. Rightfully, they presented all the approaches to this patient. She chose gamma knife, but in spite of the gamma knife, sometimes tumors grow, and this can be a perfect case for translap. Early fat gets retracted over time, and you don't see any cerebellar issue, grade 2 facial function outcome. Preservation of facial function in retrosigmoid approach, that's also possible, right? Advantage, possible hearing preservation, same time, you have better control of lower cranial nerves, no question, shorter exposure, and we are more familiar with this approach. Disadvantage, lateral cerebellum is exposed. Doesn't matter you use retraction or don't, you expose the cerebellum. Patients feel more sick after the surgery, and this approach, you have a very poor ventral control. And like previous speakers mentioned, identifying the facial nerve in large tumors can become a problem. Then you are relying on the other adjuncts, dyes or high stimulation. And it's a perfect case. Again, in this case, we did this hearing preservation, facial nerve, grade 2, grade 1, and hearing is preserved. In this case, I show you not much IAC involvement. I don't want to spend extra 2-3 hours to do translab in this case. Retrosigmoid gives you, and this is a direct route. So sometimes configuration and the size and location and the patient's intrinsic anatomy can help you to choose your approach for that particular patient. So we did this gross total resection, same case, no intracanal involvement at all. So in this case, you don't even have to drill. You may need to drill to find out facial nerve, but it's not that difficult, these cases. Although they're large, CSF space, depth in the brainstem compression can be important sometimes, and you can achieve gross total resection. Preservation of trigeminal nerve. Trigeminal nerve is very important nerve in daily life. Even if you have a numbness, you can tolerate, but you cannot tolerate the pain. And this patient has a retrosigmoid in the where actually translab was invented. It's embarrassing to say, but they did the retrosigmoid to preserve the hearing. They lost the hearing, and tumor grows. Now patient has an intractable trigeminal pain, and they recommend gamma knife. So I think in this case, you see how the nerve is impinged by the tumor. So this is not good case for post-surgery gamma knife case. So this is a good case. You go back and clean and new route, virgin route is a translab, no hearing anymore after their surgery. You go open the presigmoid dura right before the canal. I'm not seeing any cerebellum here. Debulk to get the anatomy, and tell you the truth, I don't know why they left the tumor, because they told facial nerve was very stuck. In reality, facial nerve wasn't stuck. And with the sharp dissection, I was able to get the facial nerve easily away, free from the tumor. But the trigeminal nerve was very, very compressed, and tumor was very stuck to the trigeminal nerve. I'm going to find that segment and I show it to you. Very hard tumor at that time. See, but trigeminal nerve is different from the other nerves, very robust nerve, and it tolerates the microsurgical micro trauma. See, I am pulling, but this surgery is patient's only chance. Okay, and you go, remove the rest, sharp in this case, and then you have applying traction, because you can apply traction on the trigeminal nerve. You cannot in the facial nerve or cochlear nerve, and get the rest of the tumor. Immediate relief of her pain. Okay, immediately in the recovery room, she said, "Oh, this is happiest time in my life, last year or so." So preservation of abducens nerve. Abducens nerve it can be problem sometimes in very large and very ventral tumors. So like this case, okay? This case, translap approach, I'm gonna go find, and in this case, also is a good case to preserve any arteries passing by, like the AVM vessels, and not taking them. And it's these large tumors and long axis tumors can also cause significant compression on the lower cranial nerves. You have to preserve them. And this tumor, different from the others, have very ventral presentation. So you need to watch the abducens nerve in this case. Facial nerve is another story. So I'm coming there. I'm going to see abducens nerve. You guys see here, and there are two abducens nerve. Abducens nerve is actually bifid. And this is rare finding, and be aware you don't confuse the abducens nerve, and then you don't take the nerve. And then you come, once you free from the abducens nerve, sharp dissection techniques, come to the facial nerve, and use sharp dissection as much as possible. Once you create the plane, you can do little sweeping motions, but use the semi-sharp or sharp dissectors to do that. And here, arachnoid knife, create a plane. Instead of pulling and retracting, you retract the tumor, like Spätzler doing the cavernoma brainstem. You counter-retract with the other instrument. And this is the brainstem. I'm using my suction. Suction hand is the most important hand. Okay, left hand or right hand, use your suction efficiently. And apply traction with the suction, but same time, I'm not sucking too much. Okay, sharp dissection, sweeping motions, and getting the rest of the tumor. And finding the plane. And that is the best way to do these practices in the lab. Clean the P arachnoid of the brain, like we see in the first speaker Maxi showed beautifully. And facial nerve stimulates at the lowest milliampere, patient is going to have a perfect facial outcome. Okay. Abducens is preserved, lower cranial nerve is preserved, and patient is cured. And lastly, I'm going to finish. Sorry, I'm taking too much time. Lastly, is the unsung hero of the cranial nerve or CP angle is the nervus intermedius. Nobody talks about it, like nervus intermedius is not present. It doesn't exist. Okay, so you can preserve nervus intermedius in small tumors and large tumors. Even the patient lost the taste function, it's compensated. If patient is not complaining issue, that means it's already compensated. So, but find and identify the nervus intermedius, translab again. I'm going to jump all these. So we cut the cochlear nerve. You see, that's the facial nerve. That's the nervus intermedius. Very robust in this case. Follow it like you are preserving the facial nerve, and preserve it because taste is the important function too. You cannot eat or you cannot drink good Italian wine. Even if you drink, you don't taste it, what's the point, right? So general principle tricks: correct selection of the patient, correct selection of the approach, and patient's hearing and facial nerve status is very important when choosing the correct approach. Be versatile, learn all these approaches, okay? Don't rely on the other disciplines, and be familiar. And don't, please, 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 don't try to be minimalist. Be maximally safe and efficient, and you have to know the anatomy, and correct surgeon discretion is very important. Gross total resection or near total or hybrid, but don't do the surgery with the low standards, okay? Keep your goals high. Go there to perform the gross total resection. These are the things. And another thing I learned from Taka, high stimulation. If you have a hard time to finding the facial nerve cores, you can use high amplitude stimulation, and then you can try to predict where it is going to be. And I use sodium nitroprusside. I used to use popeverin. It prevents the very small capillary vasospasm, and correct orientation, preservation of nervus intermedius. We talk about these. These are all things you guys do anyway, you know, and I don't need to talk about it. And I have a rough estimate. I don't know correct exact number of the cases, but my just crude introspective review. These are my results. Facial nerve hearing preservation, 50-50. Some years go to 60%, some years go to the 55%. All depends on the cases. But you don't go there with the, setting your goals low. So you just set your goals to get the 100%. A new generation should be doing that. How are we going to achieve this? We're going to go to the lab. We're going to learn. We're going to learn all these techniques. We're going to learn gamma knife. We're going to learn endoscopy. We're going to learn open skull base and dissect. If you see, you understand better. But if you do, you understand perfectly fine. So thank you very much. Thank you for taking time. And again, I appreciate this wonderful opportunity.
Thank you, Professor Baskaya. It was a great pleasure for all of us. Beautiful, beautiful presentation. We learned so much, and thank you so much, because we are very happy because almost 100 people and 100 guys are here online, and they are recording this presentation, and it will be available very soon on our media channels, as Professor Zileli shared every time. Thank you so much. Appreciate it once again.
You're welcome.
Beautiful presentation. Beautiful. Basic techniques, microneurosurgery. Microneurosurgery is the basic technique for everything in neurosurgery, and we share the same philosophy. Okay, it's time to move because we are